We'd like to welcome Dr. Martha Gulati today, and this would be our first interview for our Women in Cardiac Imaging section of the SCCT. Dr. Gulati, who needs no introduction, she is an amazing women leader for us. She is the president-elect of the American Society of Preventive Cardiology and an SCCT member, and has been gracious to join us today. Dr. Gulati, thanks so much for joining us.
Oh, thank you for having me.
We have a few questions that we would like to ask you and have a conversation about women in cardiovascular imaging and medicine. To help set the stage for our conversation, maybe I'd like to get started with your recent publication in JAHA addressing the challenge of women being underrepresented in the world of academia. We know that women are underrepresented in clinical practice, and it's not just that, they're underrepresented in research, in authorship, in leadership roles. And I would like you to talk to us about some of these challenges that women are facing today.
Yeah, this was a really interesting paper, and I will tell you, actually, a fellow in training, Dr. Devesh Rai, actually led this work, and I was so fortunate to be working on this project with him and many other great fellows in training, as well as cardiologists that are interested in this topic. And Devesh really wanted to ask the question, you know, where are the women in guidelines? And of course, it's probably no surprise to anyone that, you know, there's less women on guidelines. And that was true both in the United States, but internationally. We looked at the Canadian statistics and we looked at the European Society of Cardiology, and we saw the same trends. It's slightly getting better, but it still is disproportionately male on all the guidelines, including just being a member of the guidelines, but of course, even more so being a chair of guidelines or even a co-chair of the guidelines is less likely if you're a woman. And of course, like you said, there's part of the reason, and the reason this is obvious, is that we don't have enough women in cardiology. So that's the first problem, is that we've struggled getting enough women into cardiology, and we've struggled in terms of that growth. And it remains something that is a challenge within the cardiology community, as it is for the imaging community as well. I think that, you know, this has been a challenge for our society in general. How do we open the doors? How do we get more women at the table? And then ultimately, how do we get them involved in clinical trials? Because the people that get involved in guidelines are usually people that have led trials. But if we don't have enough women in clinical trials being invited to lead trials, they're not going to be recognized and be asked to be on guidelines. Because if, you know how it is when we remember late breaking trials and big important studies that come out, we usually remember the first author or the senior author, and we don't always remember the people inside. But all of it matters, because it matters who's leading the trials, but also who's in the trials as well, which is important, because we generally see that at all levels of clinical trials, we don't have enough women. And that, again, is partially due to the fact that we don't have enough women in cardiology, but also that women aren't asked to lead these trials. We have a substantial number of female investigators, and we need them to be leading trials as well. We know that when women lead trials, there's actually more diversity in those trials. There's more women included, there's more people of diverse backgrounds invited to be part of the trials, and there's considerations made in that study. How do we get a more diverse representation of our society? That's been a big issue within cardiology overall, is that so many of our trials really have focused on men, and particularly white men. And we certainly know we don't have enough women in many of our clinical trials, but we also don't have people of diverse backgrounds in enough of our trials as well. So there's a reason, an argument, I would say, that you can make for why women need to be involved in clinical trials, and hopefully also why they should lead clinical trials, but ultimately it will influence who gets on the guidelines. I think also we saw in our study is that when a woman was a chair of a guidelines, there was again a more diverse mix of men and women within the guidelines as well. And that's an important thing. And I think that all of our societies are being more cognizant lately of, what is the makeup of any writing group or any guidelines. And I think that's good. And the only purpose of our paper was to shine some light on it, to make it, here's the numbers, here's where we are now. Let's hope that in 10 years, we're in a very different place. And I think that's really, we know that there's, people would say, of course, there's maybe more women represented actually on the guidelines than there is % of women within the cardiology field. That it might be true, but we still, we would like it to, our community to look more like our society.
For sure, I cannot agree more. I think I've seen a lot of women being more excited about joining internal medicine, joining medical school. We've seen those numbers go up, but we still struggle with them continuing their aspirations to come into cardiology. And that is certainly something we need to work on to get more women into our field so they can be part of the ever evolving field of cardiology that we all love. As yourself, Dr. Gulati, you've served numerous leadership roles and on societies, on advisory boards, and including recently as the chair of the 2021 chest pain guidelines that came out. I wanted to ask you about your experience and your perspective in guideline development process, and maybe some ways that you can suggest to our listeners how they can carve out this pathway for themselves in academic cardiology, academic medicine, and leadership roles.
Yeah, I think guidelines is something quite interesting because, you get invited to, whether you're invited to chair them or you're invited to be a part of the writing group, it really is a little bit of a mystery who gets picked. And I think part of one of the comments we made in our paper about guidelines is that there should be a little more transparency. So it's not that someone can necessarily apply and say, hey, I want to be on the writing group of these guidelines. What they try to do, and rightfully so, is pick the experts in the field, right? That's the voices that need to be there. I think otherwise the guidelines don't have as much value to our community if it isn't people that are at the front lines, whether we're talking about, chest pain guidelines, who's doing the studies, who's enrolling the patients in those kind of trials, trying to figure out what is the best method for determining, is this cardiac or non-cardiac, what's the next test? So we need those people there, but we also need, as a cardiology community, to also think about obviously who needs to be represented. So I'll tell you just for the chest pain guidelines, since that's my only experience, so when I was asked to be the chair, and they had already actually picked the 2 co-chairs, but they were talking to me after they picked the co-chairs, and they told me about the whole process and, what would be involved. And to some degree, I don't think anyone can predict entirely what's involved. There's always politics involved in writing of the guidelines. And people who know the chest pain guidelines, these were the first chest pain guidelines. So it isn't that we were updating a previous guidelines. There had never been a chest pain guideline. But also, making sure that all the imaging societies are fairly represented is important. And it took us 4 years to make everybody happy, almost 4 years to the date of their release. And so there is politics involved, of course, around this. But I will say, from the standpoint of me as the chair, how did I get to choose the people that wrote the guidelines with me? Well, like I said, first thing is that we knew that we needed all the imaging societies included. So first what we did is sat down and said, who needs to be at the table? Well, we need somebody from SCCT. We need somebody from the American Society of Echocardiography. We need somebody from the nuclear, someone from cardiac MRI. We need interventionalists. So we knew who we needed there. And then we had to find experts, obviously, in addition to that. We might have had some weight, I suppose, an opinion about who should be the people, the other people. But for the imaging societies, just so people know, it was the imaging societies who nominated their own people. So SCCT, when we said we would like to invite you to be part of our guidelines, please give us names. Well, they gave us names, and then we got to decide from the two, maybe some of them gave us 2 names, and we would choose from them mostly based on what research they had done in the field, and sometimes based on, you know, knowing if we could work well with that person, but also what kind of background did they come from in terms of enhancing diversity. At least for me, that was an important consideration. I wanted to make sure that I had women well represented. I wanted people from more diverse backgrounds on my guidelines. So those might have weighed into who we chose, but we didn't choose, like we didn't go to SCCT and say, hi, we'd like to have Ron Blankstein, for example, on our guidelines. No, they gave us the names of who they thought should be on the guidelines, and then we chose them based on their expertise and other considerations. So that's why it's so important for us to be involved in our communities. And by that, I mean, of course, American College of Cardiology is our overarching community, but also the communities of our societies where we specialize. So for example, SCCT, being an active member, being a participant, someone knowing the community, you're more likely to be chosen that way perhaps than the bigger ACC community. And that's why I think people might think like I got to go out and cherry pick all my friends. I'll tell you, I became friends with a lot of these people because we wrote the guidelines. Not that I knew all of them before, or I might have known their work, but for a few of them, I'd say I never spoke to them before in my life until we wrote the guidelines. And after, almost 4 years of working together, we all got to know each other really, really well. And I would say now, I would say they're all my friends and a great bunch of people. And not that we always agreed on everything, but we learned to respect each other and respect our differences. But I would say that the community from which they came from were often their specialty societies. And that, I think that's a way to make it clear within that community that you have interest, or for them to know what work you're doing, because they're also trying to find the experts. They're not usually, I don't think anyone was just choosing people out of thin air saying, this person would be good just because, he'll represent nuclear well, or he or she will represent cardiac MR well. It was more, this is the expert, this person has done most of the research in this area. And so that's why they should sit at the table.
That's great. I completely understand. And that's something I feel that I've noticed as I've gone through my training process, that as you start your training, you're interested in certain topics of research, you build your path towards something bigger. And as you evolve in this field, you'd probably suggest starting off early, getting involved in different opportunities that you could get maybe, and then hopefully have a pathway towards more research and society involvement.
Yeah.
I also was thinking to ask you about whether these differences that we see in representation of women, are these across specialties, or I know we talk about cardiology and imaging, we talk about different specialties within cardiology. How do you feel about these differences existing across specialties? For example, we have radiology representation in our imaging societies as well. And do you think that this pertains across the board, or this is more of a challenge for cardiology or specialties that are more difficult to pursue, or have a perception of being difficult?
Well, I think every every community within medicine would say there's problems with getting women until we get an equal representation of women and men. And so there's only a few specialties that I would say have achieved those kind of numbers that we aspire to. Specialties like obstetrician, gynecologist, specialties like pediatrics. For many of the other specialties, we struggle, but I would say cardiology specifically struggles the most. We know for our fellows in training, it's about 20% women, which is much better than back when I was training. But in terms of active practicing cardiologists, we're still hovering around 14%. And we still don't have enough women at the table in general. And that means practicing cardiologists or in leadership positions, we just don't have enough women. I think even urology now as a specialty attracts more women than cardiology. The only specialties that I think are doing less well than us might be orthopedics and neurosurgery. And orthopedics is making a huge effort to increase its numbers. I don't know a lot about neurosurgery making the effort or not. And cardiology, we keep talking about this. And of course, I think there's many great initiatives underway, including what SCCT has, a group for women in imaging. And I think that's fantastic. Making people feel included and that they belong is an important part of making people see people that look like them, or that they realize that this community wants them to be part of it. And how do we level out the playing field? And I think within cardiology and as well, the American College of Cardiology this year has made huge efforts. We've taken internal medicine residents and opened the doors to them. So how can we help them, the women that want to do cardiology, how can we provide the mentorship to them at the earliest stages so they can be successful? And I think, we need to continue to measure, does that make a change? Did our initiatives change the number of women that are ultimately accepted into cardiology? And does it make people at even more junior stages feel that this is a place that they want to be? We know that it isn't that the demands of cardiology are somehow worse than other specialties, because general surgery, certainly I'd say that the demands of their specialty can be very hard, and yet they've attracted more women. I would also say obstetrician, gynecologist, their schedule and call schedule particularly, and the predictability is much worse than a cardiologist, and yet they've attracted women. It's not that women are scared of being on call. It's not that women are scared of doing hard work. I think what the problem has been, and when we've asked women, why they are not interested in cardiology, is that nobody has opened the door to them. They haven't been made to feel welcome. They haven't found mentors. And I don't think that women need mentors that are women, although it's certainly nice to have people that you're visually seeing that are successful in their career and kind of look like you. I mean, I think that always helps. But many of us, our mentors were men, because there wasn't that many women in cardiology when I was training, and they were wonderful. They never made me feel, as a fellow in training, or even when I was a resident saying I wanted to be a cardiologist, they never made me feel that there was an obstacle just by me being a woman. And I will always appreciate that. And I think that opening doors, though, is what you want. So when you tell somebody, I'm interested in your field, they should be the first one to open the door, or to look at our fellows in training, or even earlier, I would say our medical students and our residents, and saying, you're really good at cardiology. Have you considered cardiology as a career? What can I show you that might make you interested to join our troops? And I think that is where it starts. All of us have a story of what helped us decide to do cardiology. For myself, I was a second-year medical student. I was loving my cardiology rotation, which was a part of our core part in that year. And I had a cardiologist. His name was Dr. Len Sternberg at University of Toronto. So shout out to Len. But Dr. Sternberg said to me one day, you're really good at reading EKGs. Now, would that make you a great cardiologist? who knows? But that was something he noticed, and he said, you should come to the cath lab with me tomorrow. And where was I the next day? I was in his cath lab, and I got to, you know, access the artery. I think I was so excited by seeing arterial blood pulsate at me that I stood there for a while going, this is so cool. He's like, okay, we need to enter something now in place. And of course, at that point, I thought I wanted to be an interventional cardiologist, but obviously I saw the light. Don't hold that against me, Nidhi. But at that time, it just took somebody saying, you'd be great at this. Come join me. Come see what it is to be a cardiologist. And this person has been a really important mentor to me. I'm actually still in touch with this cardiologist. So many years later, every time I go back to Toronto, I meet up with him because I consider him essential. He opened the door for me. And we should remember that when we see our young trainees that haven't made up their mind, who don't know what being a cardiologist is. If we see something in them, or they seem interested, or they just seem smart, which is pretty much every medical student, let's try to open the door, help them consider, could this career be good for them? Because I think one thing we should always remember is there's always room for more. We need so many different people in cardiology, from different backgrounds, from different ethnicities, from different racial profiles, and from different genders. And there's no plateau. Just because we've only had a small number of women, we shouldn't feel that we can't open this door wider to more women, because it's going to improve this field in general for all of us if we're all there. And if we, one day, I hope we will say, oh, there's 50% women and 50% men, and great. That's what we should be looking for.
That's great to learn from you, Dr. Gulati. I cannot agree more that seeing people like yourself as a woman leader, as a role model, it's so inspiring. And that has been my personal inspiration to be in cardiology and continue my work in cardiology. So I'm sure our listeners are going to love this talk with you, and they're going to learn how inspired you can be just knowing your path and how things went for you when you were training. On that note, I do want to ask you about how you think these challenges that women face about underrepresentation, how do they vary from training to early career to mid to late career? Is this something that what's your perspective on how these things might change?
Yeah, there's different things that happen at different stages. And if we're lucky, when you're a fellow in training, for example, I hope none of you experience anything adverse. I hope those environments are as good as the environment I experienced at University of Chicago, where I felt, certainly there was things that occur that could have been better, but in general, I would say we were never made to feel like we weren't welcome as cardiologists. But I do think at certain places, especially places that don't have a lot of women, there can be both macroaggressions and microaggressions that occur to women. And we've all heard these stories. We need to create safe training environments where women don't experience these things. And I hope it's getting better. I think where we are in positions of power or leadership, that we do everything to make sure that everyone has an excellent training experience and doesn't deal with the kind of crappy things that shouldn't even be part of training, that we should just be supportive and try to be considerate and think about the things that people sometimes that are unsaid or said under the breath, or jokes that, might be even not intentional, but they can be hurtful. And I hope for trainees that we stand up for them. So us as attending when we hear things like that, we should stop them and say that joke was inappropriate, because it's very hard for a trainee to ever say that. Mostly they have to laugh or giggle or whatever and just kind of brush it aside and move forward. Because if we spent all day talking about the small stuff, we'd never get any work done, right? But I think when we enter the career as an early career, there's different things, because I think that's usually the first time that people realize just some blatant discrimination. For example, salaries. When you're training, you're just excited, first of all, to find a job after so many years of, you know, training, and now somebody's actually going to pay you for your work, and it is very exciting. But one of the worst things that can happen is when you are hired and then you realize that you are actually underpaid than somebody that they hired at the same time, or that's just a few years above you or below you, and you realize they got paid more. I think the one thing our community really needs to do is have more transparency about how we pay people and be honest about it, so that everyone feels validated for the work that they do, but also don't feel undervalued. And I think that that is something just across cardiology overall is a big issue. And we know that women are underpaid. We know this just worldwide for every job, but in medicine, where the gaps are great, there are huge gaps between men and women. And where are the gaps the greatest? In the highest paid professions within medicine, and that tends to be cardiology and orthopedic surgery, where the gaps are particularly glaring. And I think that there's a lot of job dissatisfaction once you find out. You might like everything else about your job, but when you realize you're paid less than somebody who's your equal, it makes you doubt, like, what's wrong with me? Why didn't they pay me the same? And also you start disliking your job. You're like, oh, I always say yes, I do everything. I'm the team player here when nobody else wants to do it. I go on every committee, or I do everything my boss says, and yet I'm not getting rewarded the same as somebody who might be a man, who might actually also say no to a lot of things. And so I think that we need to improve our environment. And I think at early career, sometimes you don't know it right stepping off from fellowship, but it starts coming to light at different points when you realize these issues. And I think it also affects people as they get promoted, whether they're in private practice and start, whether they're taking a leadership role in the private practice, or whether in academics you're going up for promotion. Women go up for promotion later, sometimes by choice, sometimes because of childbearing, and sometimes because they don't think of them. Their boss may be like, okay, this person needs to go up for promotion, and that person happens to be a man, and they don't think about the women. They also make assumptions about women. Women may or may not be having children, but even if they're having children, there's no reason that they have to delay going up for promotion. Just because you're a woman and just because you're having children doesn't mean you're on the mummy track, as people call it. You can do both. We've seen many women do both. And for some women, they might have a different set of circumstances. They may not have children, or they're choosing not to have children, or they may not be able to have children. And additionally, they might have a spouse at home who takes care of a lot of the things that would not delay them in terms of promotion. And I've seen that there. I've seen a lot of women where their spouses are way more helpful than you'd realize, and they are making it possible for that person not to step off or delay their time for promotion. So I think we just need to reevaluate how we think about both men and women. And I think that really is kind of, I know you wanted to talk eventually about the paper we wrote recently, but that paper, I know it was directed at women, but I will say that there's a lot of the issues we brought up are actually issues that are for men and women. And I think when we make it a man and woman issue, or a non-gender based issue, we can do better. We can realize it's going to make our environment overall better for anybody who is practicing cardiology, and that will make our place more welcoming to everyone.
Absolutely. And on that note, I'd probably have us dive into some of these family and childbirth related challenges that women face in their training, in their practice. And I know navigating this can be really tough. what would be your perspective or advice or on the resources that might be available for women to help them navigate these family pregnancy challenges as they go through?
Well, I wish it wasn't, I wish the onus wasn't on the woman in cardiology or the woman in medicine. I think the onus really should be on the leadership within the hospitals or within the practices to figure out how can we best support the women in our practice to make it possible for these life events. I mean, it's a normal part of life to have children and to you know, need maternity leave and things like that. And I think we need to make it, put more of the onus actually on the institutions per se, so that they know what's expected of them in order to have women in their work environment. And I think within our paper, you know, that was published in JACC, I hope people will go and look at the supplements. I know that's really weird to ask people to go and read supplements, because I know many times I'll read a paper and I never look at the supplements. But the reason we put them in there, and we knew it was too much for the paper, we already were, JACC was quite generous in the number of pages they allowed our paper to be. But the supplementary pages are both for the hospitals, the practices, as well as the women, because it provides the legal framework for the legality around maternity leave. Right now, you know, the United States particularly is the only Western country without a national paid family leave policy. That puts people at a disadvantage because, you know, in some states we may have really great resources. For example, Massachusetts has great resources. On the other hand, many other states have no maternity leave and no intention of providing something that they don't have to. But on the one thing that we provided, though, is the things that are illegal. And that's what I think is really interesting about our paper, is that when you read it, that there is quite a number of people that wrote in things in our survey. And we found that a great number of them had actually experienced things that, you know, troubling practices. Actually, 3/4 of our respondents reported troubling practices that are actually illegal in many circumstances. And that's why we felt so strongly about providing that supplementary material. It's what the legal laws say, is the first off. And then resources for institutions or for a woman in cardiology, for example, to take to their HR to say, listen, it is, you know, if you're not giving me a place to pump, that's illegal. If you're not giving me time for leave, that's illegal. If you're calling me while I'm on maternity leave, whether it's called maternity leave or if it's your sick leave, whatever's provided to you, they actually can't contact you when you are out. And yet many women reported that they are still answering emails. They're being asked to answer their patient questions because nobody else knows their patient. You know, so these kind of things were really happening to women in cardiology. And I think that those things, I think we all, you know, we just do them because we're soldiers in our community, and we just like, we want to come back and have a good relationship with our coworkers and with our boss. But these things shouldn't be happening. When you're taking leave, you really should be taking leave. And it's interesting because we wrote this paper with 3 lawyers, and they are actually great resources as well. And so they are from the Hastings College of Law, the Center for Work-Life Law. And this particularly the senior author on our paper, Dr. Joan Williams, she is an expert in this area and actually has been the author of many of the cases that have come up about women in all professions, to be honest, not medicine, where they fought for laws to be put in place related to women and maternity leave. So first of all, Hastings has a huge resource. The Work-Life Center has tons of resources. We put them into the document as well. But you can also go to that site and even access these lawyers who will help you through difficult, challenging times, which I think people don't realize, but these are they turn out to be women, but they are women lawyers who are really helping us advocate for this. They were shocked to learn what was going on in medicine. So much so that actually is what inspired me to do the survey, was when I was at a meeting with Dr. Williams, and when I mentioned something that's just kind of normal in the cardiology community, which is paying forward your maternity leave so that nobody else takes your call. And she's like, what are you talking about? That can't happen. And there was a bunch of cardiologists, and we were all like, oh no, that always happens. And she was shocked. And I was like, okay, we need to find this out, and what's legal, what's not legal. Because for me, the biggest issue as a chief of cardiology at the time was trying to hire women, and particularly in a state that really, and a hospital that didn't have any really good regulations to protect women. I found it very hard. You know, we'd lose out women who would choose to go, especially early career folks who knew that they might want to get pregnant, and they will choose a place that's more welcoming environment for them, given that they know what might happen in their life. And I don't blame them, but it made it very hard because we're not playing on a level playing field. And I think that this paper was really inspired on how do I get more women into cardiology, and to make young women see how welcoming we are. It needs a federal mandate, but it needs us as a community saying we're not going to stand for this anymore.
I completely agree, Dr. Gulati. I've seen so many coworkers and even in training who struggle with keeping up with their professional activities, and then going through pregnancy, taking care of their little child right after pregnancy, with a very variable, as you alluded to, very variable maternity leaves that they are offered.
Yeah.
So I think this is definitely a challenge that many women in cardiology would appreciate finding these resources. And this paper definitely brings this to light and highlights these challenges. So I'm thankful that you really led this paper and helped us highlight and emphasize on this one particular aspect that women face. I think delving from that note, I know we've talked about underrepresentation of women in cardiology. We've talked about family and pregnancy challenges that women face as they go through their career. I think the other question we had for you was, what would be the first big change that you would like to see in helping women cardiologists, women physicians succeed? What would be that one thing, one big thing?
I think perhaps the biggest thing we can do for women in medicine in general is really the things that we've been talking about, like making sure that we are bringing women into leadership roles, that we are recognizing their accomplishments and recognizing the importance of a more diverse workforce. And I think that it's just changing what we used to consider norm. You know, if you sometimes you'll go to different medical schools and you'll see on the walls all the past chiefs or chairs of the department, and they do tend to be predominantly and historically, understandably, men, and often white men. And I do think it's getting better, but we need to be pressing to keep changing that. And because it's not that we're trying to do it as tokenism, but it needs to become a norm that you can have men and women in leadership. Their leadership style is going to differ. There's things about that are maybe more stereotypically women, and some things that are more stereotypical men. But until we see them in leadership roles, we're not going to be accepting of things that are different. And so I think the biggest thing is that as we push at all levels, the one that perhaps is the most important is pushing in the leadership roles, because that has a trickle-down effect for literally everyone in the community.
Great. I hope to see more women who are aspiring to be in those roles and rise up to the leadership forums and leadership roles. I hope that we can make that effect. to that note, what do you think men can do? Men in medicine can work together with women. How they can work together with women, or what they can do to effect these changes?
Well, I think the most important thing is to remember the men. There's many great men out there, and they want to see more women in leadership, and they want to see women rise, and they're advocating for us. We need to engage them in the programs that we're doing to advance women. So don't, I think, whenever we have a group of women in cardiology or women in cardiac imaging, make sure you have some male members, especially the men who have power, because you're going to come up with great ideas. But often currently our leadership often has a lot of men. You need them to be pushing at the highest level. It's one thing when we're talking in a room of like minds, we need it to go up to the people that can give the money or give the ability to make change. And so the allies we always will need, and we call it, the hashtag is he for she. We need them in the room, and we need them pushing for change at the highest levels. And I think we shouldn't forget the male allies, because they are going to be the greatest advocate for change for us. In our current state, they are the ones that often hold the power or have the right connections to people that will really influence change.
Great. The last one that I have for you we wanted to have some fun note to our conclusion of this interview. And I know, we all know that you have so many amazing accomplishments. And many of us wonder, including myself, how is it that you're able to do so much in one day? So we would request you, if you could walk us through your morning routine to how you get yourself ready for your day.
Yeah, most of you, if you follow me on Twitter, perhaps know how I start my day. I'm very big about routine. I think most of us in medicine are. And my routine since I was a child has always involved running. When I was a kid, I think I used to get up so early that my parents didn't know how to tire me out. So eventually my mother asked my father to take me someplace early in the morning so I wouldn't play the piano at 5 a.m. And so my dad took me to a field, and he said, go run. And yes, I did. And I guess I never stopped. But every day for me starts with a run. It's, for me, a great way to clear my mind and, think about what I'm going to do in the day, or think about nothing, to be honest. Sometimes I'm singing in my head, or just, enjoying what I'm seeing, the sunrise, and my dogs. I run with both my dogs. I'm actually somebody who doesn't even take a day off of running. I run literally every day. I don't believe in days of rest. I know it probably goes against anything in medicine, but I don't take days of rest. And for me, it is the way that I feel good every day. I feel, if there is a rare day that I miss running, which really is really unusual, the whole day I'm off. I'm always thinking about, well, I didn't get my run in, and I'm kind of crankier. And so I've just learned it doesn't matter. Even if I have an earlier start, I just get up earlier, because I know psychologically it doesn't work for me to miss my run. And I think finding whatever that, we all need those moments in our day, those moments of joy, and moments that are just ours. And whether it's, some people aren't morning people, I get that. So maybe it isn't in the morning, but whatever time of day, to make some time for you, because we do need, we talk about the diastole, we're always in systole all day long. Some point of diastole should exist in every day. And for me, that is when I'm running.
I love how you compared it to our systole and diastole. I am definitely motivated. I'm going to start to work myself in the morning and try to get to a run, which I never can do, but this time I'll definitely try. Coming to our final concluding thoughts, Dr. Gulati, I want to first thank you for joining us, for starting our Women in Cardiology and Women in Cardiac Imaging series of women leaders. And we all have learned a lot from you. And I'm sure our listeners will enjoy listening to this conversation and learn from our talk today. Concluding thoughts, I wanted to ask you if you had your final 3 pearls for women in cardiac imaging that we want our listeners to hear from you.
Sure. I would say the first thing is women belong in cardiology and also in cardiovascular imaging. I think there's probably no area more exciting than cardiology. I mean, and particularly imaging, and I'm not an imager, I just use it, you know, so I feel a little bit fraudulent even being on this platform. But I'd say, you know, all the exciting initiatives with cardiac imaging, whether it's for me as a preventive cardiologist, how I can use it, but there's tech, there's artificial intelligence, there's so many things changing. And we need women and the interesting ideas that will come from women as much as we need from men. And I think that is the first thing to remember. You belong there. I think also for those of us within cardiology at different levels, whether that's early career, whether that's training, whether it's at senior points of our career, remember to apply for positions, whether you're not going to get them if you don't apply. So if you want something, nominate yourself. And or ask somebody. You can always ask me. I'll always freely nominate somebody who wants to do it. I might just ask you to do the paperwork. But also nominate others. Think about other junior people. Be their advocate, be their ally. Think about sponsoring a young trainee. And that can be, even as a fellow in training, you can think of somebody that's junior to you that you want to see rise up, that you see something in them and you know their greatness. And mentor people as well. I mean, that is our job, no matter where we are. It is so important. The third thing I'd say is remember that there's room for everyone at the table. There isn't a finite number of women invited, and it isn't a competition. I think sometimes people forget that. And I think we should really think about bring more women. The only way we're going to get to that 50% is to get more women there, and we're not anywhere near it. So bring more women to the table. And I know you only asked for 3, but I'm going to add a 4th. Amplify other women when you can. It doesn't always mean that you agree with them, but when they speak, I think it's much harder for women's voices often to be heard. It's just a nature, our voice, many of us are soft speakers. I'm definitely one. And I think sometimes it's hard for me to get my voice heard in meetings. And I think one of the greatest things we can do is when a woman has an idea, amplify her voice. So if you say, I think it's a great idea to do X, if I'm in the room, I should say, oh, Nidhi had a great idea. I love that idea. Did you hear what she just said? She said we should do X. What do you all think about that? That actually works and helps raise the voice. It reduces the bropriations, as they call them, and the manterruptions that occur commonly within our community. And I think these are little things, little tricks we can all do for each other to make our environment better for all of us.
Those were fantastic thoughts and great advice, Dr. Gulati. I certainly learned a lot myself, and I'm sure people who are listening to this can get something from this talk and be able to apply it to whichever stage in their career they are. And I again want to thank you so very much to being with us today and sharing your insights into how more women can be part of our wonderful world of cardiology.
Thanks for having me, Nidhi.